Hey guys, what's up? I'm Dr. J.
I am Dr. I, and this is Second Opinion with the Twin Doctors. All right, my favorite part of the day. Doctor, give me the news.
I'll tell you what's in the news. Everybody's talking about methylene blue. It is like the nootropic agent for the new generation. Everybody's using it. Joe Rogan, RFK Jr., Mel Gibson, everybody's saying that it boosts brain power. But the question is it true? Well, it turns out it may very well be true. Research has shown that methylene blue does two things. Number one, it increases the production of ATP in your brain cells. That's like fuel for your brain. Number two, it increases blood flow to the brain. More blood, more oxygen, more sugar, better function. So, is methylene blue the nootropic agent that everybody should be using? For the most part, yes, but not always. People with depression, for example, who are taking antidepressants should not use it. There is a risk of a very significant side effect called serotonin syndrome. So, as is oftentimes the case with any medication, any supplement, any nootropic agent, talk to your doctor first. But that, sir, is what's in the news.
All right, now on to our topic of the day. STIs on the rise. Surprising facts you need to know. And joining us, we have Dr. Sadaf Lodhi. She's a board-certified OBGYN with offices in New York and Michigan. Thank you so much for joining us, Dr. Lodhi.
Thank you so much for having me.
Of course, it's an absolute pleasure. So before we get into the main topic, I want to ask you a little bit about your podcast. It's called the Muslim Sex Podcast. And I have to tell you, when I saw the name of it, it stood out right away because, what's that?
It caught your eye,
It caught my eye because rarely do you think of sex and religion in the same context. But in reality, no matter what your religion, be it you're Muslim, Jewish, Christian, clearly everybody's having sex because we're all here. So what is the podcast all about?
Yeah, thanks for that question. Yeah, it's a funny name. So basically, the podcast is a podcast that seeks to empower and educate people globally about sexual health, about perimenopause, menopause, and all things GYN related. I came up with a name with a friend of mine who, and this was back in 2021, she and I were having a conversation, and she's like, wouldn't it be great if we had a podcast and I would ask you questions? She's a lay person. She goes, you're the doctor and this and that. And then, we started thinking and brainstorming about the names. And she said, I have an idea. She's like, why don't we call it the Muslim Sex Podcast? I was like, no way. There's no way I am calling it the Muslim Sex. I was just like, why not? It's very catchy, and people be like, stop and be like, what the heck is this? And it took a while for me to kind of wrap my head around the name, but then, I did my own little, mindset readjustment and thought about it. And, I think that what I realized is that there's a lot of sex negativity that perhaps a lot of cultures grow up with, that I grew up with. And so I worked around that. But, it's a really important topic, and it helps to erase stigma and taboo in these very important conversations.
Yeah, 100%. Well, your friend was right. The name caught my eye.
Oh, for sure. Yeah, 100%. For sure. All right, well, thank you for that. Okay, getting on to the topic. So, why are STI rates rising so rapidly in the United States? What is going on?
Yeah, so, the thought is that there's less preventative services and weakened public health infrastructures. There's been a lot of funding cuts that we've seen in the news, and clinic closures and reduced screening. And, this was exacerbated during the COVID-19 when people were afraid to leave the house, and, we didn't know what was going on with the virus. And so now there's been diminished access to regular STI testing and screening. And we've also seen a change in sexual behaviors. There's been lower condom usage, more partners, increased rates of oral and condomless sex are also contributing. And some things that we don't always think about are the sexual and actually the social determinants of health, rather. And we know that poverty and healthcare access barriers, and including social stigma, right? So when people hear or think that they may have an STI, they get nervous, and sometimes they don't want to know the answers. So that could also be why they don't go in for testing.
Yeah. Question for us. So I've got an idea, but I'm wondering what you think. Why do you think that there is less condom usage now? Like in the, when we were growing up in the 80s and the 90s, there were songs about it, popular songs about condom usage, and people were using them more and more often. Why do you think that is changing as we go into the 2020s and we have more and more information at our fingertips?
Yeah, I think that, people think that perhaps something like HIV is now more of a chronic disease. We don't see or hear about people dying from HIV. I think that scare, people think like, well, I know so and so that has HIV and is doing okay with it, and there's meds to treat it, so it's probably not that bad. And they don't understand the risks completely. I think also the problem that we have is that sex education honestly is zip code based, if you think about it, because a lot of what people learn is based on where they live and who controls the board of ed. And actually I did a whole lecture on that a few years back, and we looked at the demographics of the United States and saw that what different states were learning, and some states were more focused on abstinence, some states were more focused on STI prevention. There weren't any states that talked about consent or pleasure. And so I think that people, and especially kids and teenagers as they go through adolescence, aren't getting the full information and don't really know the risks or understand the risks as well as they should.
And that kind of leads into the next question. We're seeing rates of STIs rising kind of across the board, but especially in the very young, people between 15 and 24, and then in senior citizens as well. And my question was going to be, why do you think that is? And in part, I guess you just kind of answered it, lack of education, or there's no uniformity in education.
For the younger folks, what about the older people?
Yeah, exactly. So why do you think we're seeing a rise in those groups?
Yeah, so, I think you're exactly right. Just like as we talked about for the younger individuals, lack of comprehensive sex education leads to gaps in prevention knowledge. So that's, a big problem that we have here. Now, when we talk about older individuals, I want to be careful about when I say older because, I'm getting up there in age too. So, but, we typically think of people or women that are in midlife and individuals that are above and, midlife. So we're thinking about individuals greater than 55, and rates of chlamydia and gonorrhea chlamydia has tripled and gonorrhea has quintupled, and syphilis has septupled between the 2012 and 2022. Factors such as improved longevity, people are living longer, people are they're using medications that enhance sexual activity. So, for example, medications for erectile dysfunction that perhaps people didn't have access to before are now very commonplace. You can get it online, and so people don't even have to go to the doctor. They just fill out a questionnaire and get the medication. There's lower awareness about STI risk, and there's limited screening in this age group, And a lot of women, and there was actually a whole article in the New York Times talking about how women are living their best sexual life now in midlife. And a lot of it has to do with the fact that, one, they just don't care anymore in terms of what other people think, and they just want to really enjoy. They don't worry about pregnancy anymore, but then, we forget that you still have that risk of STI. And so there's also less use of condoms because women are not worried about pregnancy. Also, a lot of older women have passed that age of HPV vaccination. As you know, the upper limit is 45. So if we're talking about women that are older than that age group, they haven't been vaccinated against HPV. So there may still be that risk of getting HPV and not. Since the recommendations for pap smear have also changed, and we're spacing them out for pap smears, people may not be going in as often to their gynecologist to get screened, and may not even realize that they have a sexually transmitted infection.
Okay, so you threw out a few of them. You threw out chlamydia, rates are tripling, gonorrhea, rates are quintupling. We're talking about HPV and the HPV vaccine. What are the 5 most common STIs in the U.S.? I'm assuming gonorrhea, chlamydia, and HPV are amongst them. What are the 5 most common?
Yeah, so, as you mentioned, chlamydia, gonorrhea, human papillomavirus. We also see human simplex virus, which is HSV or herpes, and we also see trichomonas very often. I actually recently had a case of a patient that came to me to see. She saw me in the office and she was convinced that she had a UTI, and she said she went to the urgent care. And this is how, kind of to your point of why people are sometimes they can be misdiagnosis, right? So she just goes to this clinic care, at a local pharmacy and gets treated. And, she tells the woman that's examining her, the provider, that she's having burning with urination. The provider, who happens to be just, doesn't really examine her and just gives her a medication for a UTI, thinking like, oh, she's having burning on urination, this is what it must be, then the patient doesn't get better and gets worse and worse. And so anyway, she comes to see me, and a few days later, and I do an exam of her vulva, and I see fulminant herpes everywhere. And this is why it's so important to actually go in and be examined, right? We may think that we have, because we're having burning on urination, and for sure she can't even sit, and she's like, oh, this must be it, and she's doing all this over-the-counter stuff. She doesn't realize that she actually has herpes, and so the treatment that she's getting is not going to be the one that's actually going to solve her problem. And so that's why it's really important to actually be seen and examined when you have symptoms.
I can't tell you how many times that has happened. I've had a patient come in saying that they're having burning with urination. They assume it's a UTI because they're having burning with urination, and they have fulminant herpes. They have multiple herpetic lesions.
And now you have so many services available too that allow you to pseudo self-diagnose at home and pseudo treat, and that's really kind of troubling because people oftentimes will think they know what's going on. They'll treat what they think. They'll come in later and say like, I'm a little bit better, but there's still something going on. And it's just that they've kind of missed the mark with the diagnosis altogether. And so and you kind of mentioned one already, but what are some of the more common symptoms people see if they see symptoms when they have these common STIs like gonorrhea, chlamydia, trichomonas?
Yeah, so what I typically see in the clinic is that patients will come in with a type of vaginitis, either like an irritation of the vagina, or they'll see some discharge. A lot of times they can have like a yellow or green colored discharge, specifically with like trichomonas. But some of the, when you have STIs early on, you may not have any symptoms at all, right? So they may be silent, and so you may not even know. I think one of the youngest persons that I saw that had chlamydia was 14, and she was having sex without a condom and didn't realize that what was bothering her, this irritation or this discharge that she noticed later on, was actually a sexually transmitted infection. So I think there's definitely a lot of lack of education, but the symptoms can be vaginal irritation, or they can be discharge, or sometimes you don't have anything, and you only get diagnosed if you go in, let's say, for like a pap smear, and you're being screened for that, and then we do a test that also runs like chlamydia, gonorrhea, trichomonas on that as well.
And I think that's the important thing, and that's something we'll talk about a little bit later with people getting pap smears less and less often. But yeah, a lot of patients have symptoms, but a lot of patients do not have symptoms, and just they're coming in for their routine exam, they're coming in for their pap, they want to get their birth control, whatever, and you do screening tests and you find that they in fact do have an STI.
Or they oftentimes have symptoms that they think are normal, oddly enough. They'll say, well, yeah, I do notice a little discharge, but that's normal for me, And so coming in for those regular exams, super important, 100%. But what are some of the potential consequences of these more common STIs like gonorrhea, chlamydia, trichomonas, especially if they're not treated?
Yeah, so all three of these infections definitely can cause inflammation of the fallopian tubes in men, in women, and the epididymis in men. And so we know, we've known this for a long time that, undiagnosed chlamydia and gonorrhea can absolutely affect the fallopian tubes and affect fertility in women later on in life whenever they decide, if they decide that they want to get pregnant. More and more people actually now are deciding to be childless by choice. However, for those individuals that decide they want to have children later on, these infections that go undiagnosed and untreated can absolutely affect the fallopian tubes and inhibit that progression of that egg traveling from the ovary down through the fallopian tube into that uterus, where oftentimes it can get fertilized. And then, like you mentioned, for men, the epididymis is the portion of the testicles that new sperm cells travel through, and as they make their way out to fertilize those eggs. So if the epididymis is damaged, similar to those fallopian tubes for women, then that sperm, is unable to get to the egg, and of course the tube can be scarred and blocked, and this can also lead to infertility in men. So it's super important for both individuals, both those that are born female at birth and those that are born male at birth, that they go and get tested if they have abnormal discharge or just feelings that something is not right, to definitely go and be screened for a sexually transmitted infection, especially if they're having sex with, let's say, multiple partners or with people that they're not sure about their sexual history, to definitely go and get checked out.
And this is where education is a big piece again too, because you mentioned how these infections can damage the fallopian tubes, cause inflammation of the fallopian tubes, but I'm always surprised at how many patients don't know that conception actually starts in the fallopian tube. So they say, well, as long as my uterus is healthy, is there an issue? And I tell people, no, the egg is actually fertilized in the fallopian tubes and then makes its way to the uterus. And so if your fallopian tubes are damaged, that can adversely affect your fertility.
So I think there's a lot of stigma surrounding being diagnosed with an STI as well as being tested for an STI. And I think that people would be surprised to know generally how easy it is to diagnose and generally how easy it is to treat. So for most of these STIs, how are they diagnosed and how intensive is the treatment? Because I think people are afraid. I think it's, going to take a lot to diagnose. It may be painful to diagnose, and then the treatment's going to be onerous as well.
Yeah, a lot of times for women, and for men, you can pee in a cup and you can get tested through the urine for gonorrhea and chlamydia. For women, typically for a sexually transmitted infection, we will often culture the cervix, and so it's not really that painful to get tested, and definitely to get treatment. Oftentimes for gonorrhea, we can give a intramuscular injection ×1, and also for chlamydia, it's an antibiotic treatment typically that lasts about 7 days, or you can also do 1 gram of azithromycin as well. So it's not difficult to get treated, it's not difficult to get tested, and so it's so important, and especially because we know the long-term effects of being untreated and undiagnosed can really affect you in the long term, right? In terms of your fertility and whether or not you can conceive. I think it's super, super important to be tested and treated.
Yeah. So we've talked a lot about gonorrhea, chlamydia, trichomonas, 3 of the top 5 for sure. And then there's HSV, herpes simplex virus, and HPV, human papillomavirus. What are those?
So human papillomavirus is a virus that is actually kind of two-pronged. It can lead to cervical cancer, or it can lead to genital warts. In men, typically, we'll see the genital warts. For women, we will also see genital warts. I've had patients actually that have been pregnant, and sometimes those genital warts can really go nuts, and they can develop a whole bunch because they're immunocompromised. And so then sometimes also they can be painful and uncomfortable, and so sometimes women will go and try to have those removed. And we apply an acid on them to get them to be removed. But so human papillomavirus can cause abnormal pap smears, or they can cause genital warts. And for a human, for herpes simplex virus, which are herpes, right? They can cause those blisters that we see, and that's what we were talking about earlier, where patient thought that she had a urinary tract infection that was burning when she urinated, but actually they were, she had tons of blisters on the outside of her vulva, and they can be also extend to the inside, and definitely be so painful for individuals that they can't sit, they can't work. I mean, it's really, really painful and uncomfortable.
Yeah. So we spoke about, gonorrhea, chlamydia, trichomonas, those being treatable. When it comes to the herpes simplex virus that causes herpes, HPV, which can cause warts or issues with cervical, abnormal cells, are they curable, or are they at least treatable?
Yeah, so in terms of your first question, are they curable? So unfortunately, because both of the HSV and HPV are viruses, they are not curable. And unfortunately, once you have it, you kind of always have it. And especially with HSV, which is herpes, it lays dormant in the dorsal ganglia, which is the nerves.
What about vaccines? Are there any vaccines for HSV or HPV?
Yeah, so definitely for HSV, we don't have any vaccines. So that's our herpes virus. We don't have any vaccines for that. We do have a fantastic vaccine for HPV. And so the HPV vaccine is a 97% effective at preventing the HPV infection. And but the one thing is that there are so many different strains of HPV that we've realized that it doesn't protect you against every single strain of the HPV, but it does protect you against the more virulent ones, the ones that can lead to cervical cancer. So that's why they're really important. And those strains are 16 and 18, and we do screen for those on pap smears. And those are the ones that we worry about eventually leading to cervical cancer. But I just want your viewers and listeners to know that not everyone, and this is a huge misconception that I've had to talk to patients about several, over and over again, is that not anytime somebody gets HPV, it does not mean that it's going to lead to cervical cancer, and that's really, really important. Like we said, sometimes the body clears it, sometimes it lays dormant. Like, it doesn't mean that eventually it's going to go to cervical cancer. It doesn't have to, and it may never. But if you do have it, just make sure that you have those follow-ups with your gynecologist or your provider, so that you can make sure that it doesn't progress.
Yeah, and that's one thing I tell patients quite often. If you're going to see cervical cancer, typically it's kind of like prostate cancer in men. It moves very slowly. So even if you have HPV, even if you see these precancerous cells, keep a close eye on them. As long as you're seeing your doctor on a regular basis, it's typically not going to cause issues. It's when you see cervical cancer, when you see prostate cancer, oftentimes it's people who tell you, like, I haven't seen my doc for 5 years, 10 years, 15 years. I was ignoring these signs. And so it's something that, as long as you're being closely watched, it shouldn't be much of an issue.
But you mentioned something about the HPV vaccine, which we definitely recommend for people. But a question I get all the time: okay, doc, I've been vaccinated for HPV. Do I ever need to see you again? Do I have to come back? Do I need to get my pap smears, or are we done forever?
Absolutely. So yes, it doesn't matter if you've received the vaccine or not. It's fantastic if you have, and we know the upper limit for the vaccine now is actually the age of 45. But if really, vaccination status is important, but you don't have to be vaccinated. You definitely should get a pap smear. So we know that in the 20s, when women are in their 20s, we do a pap smear about every 3 years, and once they reach the age of 30, we do a pap smear. We'll do like the pap smear, and we'll also screen for HPV. Of course, if you're in your 20s and you have an abnormal pap smear, it will reflex to check to see if there is HPV. But we don't typically go out seeking for it unless there's an abnormal pap smear. But in your 30s, we will do co-testing, which is we'll do that pap smear and we'll also check for HPV. And as long as it is normal, we will do the pap smear every 5 years. So that's how the guidelines have changed, and that's how sometimes patients can go a long time without being seen by a doctor, or sometimes they ignore the symptoms of the sexually transmitted infections that they may have, or abnormal vaginal discharge, or anything like that.
And I always tell patients too, because when they find out that they can space out their pap smears, they're normally pretty happy, and they think that they don't have to see you for 3 years or 5 years. And I always tell them, even if you're not getting your pap smear on an annual basis, you still need your pelvic exam, because while the pap smear is for cervical cancer, pelvic exam can detect issues with the uterus, issues with the fallopian tubes, and I think there's a lot of confusion when it comes to that. People think that a pap smear is that entire exam, and it's like, no, that's just a component of the exam, but you still have to come in and get the pelvic exam and make sure the ovaries are okay and make sure the uterus is okay. Do you see a lot of patients as well who, when they find out they can space out their paps, they're like, I'll see you in 5 years, doc?
Exactly. Yeah, absolutely. And we do tell them that they definitely need to come in yearly to get their pelvic exam to make sure that their ovaries feel okay and that there isn't any other problems going on. And most patients are amenable to that. Some people do find it a little bit of a hassle to come back. They're like, well, why do I need to come back if everything's normal? I'll just see you when I see you, which is okay, but we definitely don't recommend that, because there are sometimes, things that come about, like ovarian cysts that can grow really big, or fibroids that start to grow and become a problem, or heavy vaginal bleeding, or any one of those things that we definitely need to see our patients for.
Or other STIs like we were speaking about earlier.
Yeah.
I was going to ask you, so when we think about STIs, sexually transmitted infections, we think of sexual transmission, right? But are there any other ways that STIs can be transmitted?
Yeah, absolutely. So some sexually transmitted infections, like, we have HPV and HSV, can be transmitted directly through skin-to-skin contact, but others like gonorrhea, chlamydia, syphilis, HPV, and HSV can be transmitted through oral sex and or kissing. We know that if somebody has a lesion, for example, like herpes, and they perform oral sex, they can also get like those cold sores on their lips. Bloodborne sexually transmitted infections like HIV, hepatitis B and C can also be transmitted by sharing items like toothbrushes or razors. For example, if there's contamination with blood and you have like an open cut, that virus can get in that way. And also, something that we don't think of too often is also IV drug access, right? And you definitely sharing needles can cause spreading of sexually transmitted infections like that. But bloodborne illnesses, like we just talked about, hepatitis B and C and HIV can also be spread via sharing needles. And so it's really, really important to know how different sexually transmitted infections are passed and how you should be screened.
And I think people are always surprised to find out that sometimes even direct skin-to-skin contact can transmit sexually transmitted infections. I remember a few years ago there was an outbreak of mat herpes, which, from what I understand, the term comes from the fact that wrestlers who were wrestling on mats were being diagnosed with herpes infections of the skin because the mat was contaminated. And so even direct skin contact can transmit certain STIs, and I think that both surprises and scares people sometimes, but it's something that people should know.
Yeah.
Now, I want to ask you about some of the new kids on the block. There are 2 STIs that have relatively recently not necessarily been discovered, but the fact that they can cause issues with health and fertility has recently been discovered. And talking, of course, about mycoplasma and ureaplasma. Can you tell us a little bit more about these?
Yeah. So, in part, these infections, and actually I want to add one more to that
please,
list.
by all
so
means.
we mentioned mycoplasma, ureaplasma, and I don't know if you remember, but just a few months ago, the Journal of the American Medical Association labeled bacterial vaginosis as a sexually transmitted infection. And what's interesting about that is that gynecologists always kind of thought that it should be labeled as an STI, but we never said it because we knew that individuals typically, it doesn't always happen this way, but typically individuals that were sexually active were the ones that had bacterial vaginosis a lot more. And it wasn't really, it wasn't something that we really thought about too much until it came out in the journal. And there was an Australian study that recognized that individuals that had bacterial vaginosis that were treated, a few weeks later, they tended to have it again, a recurrence of the bacterial vaginosis. And then they looked into it and saw, why is this happening? And they realized that it was their partners that had it, that, when they went back to their partners and became sexually active again, that the partner was giving it back to them. And so after that, they started treating both. And that was what the study was, is that they had an arm where they only treated the woman. And then there was an arm where they treated both the partners. And they realized that the arm that treated both the partners had less recurrence of bacterial vaginosis than had they just treated the individual female by themselves. So that was a new thing that just came about a few months ago, where now they've labeled bacterial vaginosis as a sexually transmitted infection. To your point about mycoplasma and ureaplasma, in part these infections are fairly asymptomatic, like gonorrhea, chlamydia, trichomonas, and because they're so new, a lot of people aren't thinking about them, but they're actually quite common. So ureaplasma is very common and is detected in about 60% of women who are tested. Ureaplasma can be tricky because it's often transmitted through sexual activity, so we're not always, ureaplasma isn't really like, when I think of STIs, that is definitely not one that comes to mind right away, but it can be found in some women without having been sexually transmitted, and so that's why it's a little tricky. Mycoplasma, on the other hand, is considered to be a sexually transmitted infection, but it's less common as ureaplasma, and it's found in about approximately 5% of sexually active people.
So let me ask you a question. So, when you have a patient that you're diagnosed with ureaplasma, mycoplasma, bacterial vaginosis, do you automatically recommend that their partner be treated as well, or do you treat the partners only if the patient has recurrent infection? What would you recommend for a patient?
Yeah, that's a fantastic question. And I think that I would treat, because we're thinking that it's a sexually transmitted infection, I would treat the partner. Because I truly believe that unless we're treating both people, that woman is going to continuously get the same infection, and or that infection will not be treated completely. So, and because we know that, individuals that are partners will probably end up, as soon as that treatment is over, and I always get this question, by patients is that, well, when can I have sex again, right? So they're interested in knowing when they can resume their sexual activity. And I think a lot of individuals will start to resume sexual activity even before they finish the course of antibiotics, right? So I think it's really important to, when we're thinking that something's a sexually transmitted infection, it's really important to treat both partners.
What are some of the potential long-term consequences of mycoplasma and ureaplasma? Like, why has it been considered clinically significant now?
Yeah, so both of those, ureaplasma and mycoplasma, can lead to chronic inflammation and can damage the reproductive tract and lead to infertility. So similar to, when we think of gonorrhea and chlamydia, these two microorganisms can also do the same and damage it. And so, and often reproductive endocrinologists will test for ureaplasma, mycoplasma, even before we thought of it as a sexually transmitted infections. REI docs were already testing individuals for, specifically women, for these infections and
So like
treat them.
So the reproductive endocrinologist, before like doing IVF, for example, in vitro fertilization, would actually test for mycoplasma and ureaplasma.
Exactly.
That's interesting. I didn't.
I actually have a friend who's currently on an IVF journey, and before they will do implantation with the surrogate, they check for ureaplasma, everything. Yeah, they do.
And that makes sense, I guess, when you think about it, because obviously we're talking about the risk of infertility with infections like this, but also when infections like this are present during pregnancy, there's potentially some risks associated with that as well. Can you tell us a little bit more about that?
Yeah, so in terms of pregnancy and delivery, sometimes these bacteria or infections, like for example, chlamydia and gonorrhea, have been linked to preterm labor, preterm premature rupture of membranes, low birth weight, and some neonatal infections. We know that trichomonas infection has been associated with preterm delivery as well. It's mixed regarding outcomes if, was given treatment, if the patient was given treatment. We know that ureaplasma and mycoplasma have also been implicated in something called chorioamnionitis, which is basically where we know the amnion, which is kind of like the sac that the baby sits on, that can also, so mycoplasma and ureaplasma can potentially cause infections of that bag and also result in preterm birth. And also, women that get bacterial vaginosis in pregnancy, we always make sure that we treat them for that as well, because that can also lead to cervical insufficiency. So really important to know and be treated if you have these infections so that you don't have any type of sequelae from them.
And this is one of the many reasons why getting regular prenatal care is so important. So we were speaking earlier about the rise in STIs and the decline in condom usage. Are there any medications people can take that will reduce the risk of them contracting an STI if they are sexually active? Now, we still always recommend barrier protection as well, but are there medications that people can take to reduce the likelihood of contracting an STI?
Yeah, so definitely. So there are PrEP, which is called pre-exposure prophylaxis medications, and doxy-PrEP. PrEPs are medications that can be taken before sexual activity to prevent contracting HIV, and the most famous of these medications is Truvada. Doxy-PrEP is an antibiotic, doxycycline, and it's taken before or within 72 hours of a possible exposure to a sexually transmitted infection like gonorrhea, chlamydia, and syphilis.
What do you think about the use of probiotics? We have patients and we always, preach the benefits of probiotics. And obviously there's different types. There's GI probiotics for GI health and vaginal probiotics for vaginal health and immune probiotics for immune health. But is there any role in using vaginal probiotics for prevention of STIs?
Yeah, so there has been some research that's been done that's been shown that using vaginal and gut probiotics can improve the vaginal and gut microbiome, and with a healthier vaginal and gut microbiome, the vagina and gut immune system is healthier and better able to ward off potentially sexually transmitted infections causing these morbidities. And what's also important to know is that as women get older and as they get in, as they experience like perimenopause and menopause, that their vaginal microbiome changes. So with that decline in estrogen, we notice that the pH increases in the vagina, and what women can be susceptible to is like recurring yeast and bacterial vaginosis also with that pH changing. And so it's really important that as women go through midlife and beyond into postmenopause, that they start using vaginal estrogen, because that is super important, and it helps to basically correct the pH in the vagina and make it less susceptible that those individuals will have recurrent UTIs and overactive bladder, but also prevent those recurrent yeast and BV that women can sometimes get.
And speaking about vaginal estrogen, so I find that a lot of patients don't actually realize that as they go through menopause and the hormone levels decrease. Of course, I think about hot flashes and night sweats and things of that nature, but a lot of patients come in with a myriad of vaginal complaints, be they vaginal dryness, pain with intercourse, vaginal itching, things that they actually mistake for a vaginal infection. Do you recommend that patients that are in menopause routinely start vaginal estrogen, or do you recommend that if they are having symptoms, like these symptoms that seem like an infection or pain with intercourse, that they start then? Or if they're having recurrent infections, that they start then?
This is like my most favorite question.
All right.
So my niche is, perimenopause, menopause, and sexual health, and vaginal estrogen. I swear, I think that if there was one miracle drug that could save relationships in menopause throughout the world, it would be vaginal estrogen. There are very, very few, if any, contraindications. I think the only contraindication to vaginal estrogen that I've seen is leiomyosarcoma, a history of it. But honestly, there's like hardly any. And I will tell you that vaginal estrogen, not only does it save lives because it prevents recurrent UTIs, it increases lubrication, it decreases overactive bladder, it helps to replenish that epithelium of the vagina, it increases elasticity, it recruits the blood vessels in that vulva to help promote a healthier vulva. We also know that labia minora can resorb as women go further and further into postmenopause, and so it will prevent that. It increases sensitivity, so we know that sometimes women can lose sensitivity in their clitoris and decreasing pleasure, and so it helps to, because it recruits the blood vessels and helps that whole area to become healthier, it is going to help with the sensitization. So, and so I'm Pakistani, and a cousin of mine lives in Pakistan, and I remember last year when I was visiting, he was telling me that a lot of his friends, and he's like in this upper high society and whatever, so he was telling me that a lot of his friends were going to Dubai to have extramarital affairs because their wives who were in postmenopause could not have sex anymore and were having so much pain with intercourse and basically had kind of shut off their husbands. And because menopause and women's bodies sometimes in some cultures can be taboo and shame and stigma, and people don't talk about it, that the marriages were being dissolved because of this problem later on in midlife and postmenopause. And so I truly believe that if we were able to get vaginal estrogen to the world globally, that we could help save marriages, prevent recurrent UTIs, prevent women from dying of sepsis. And I think that it's such a medication. And we know from studies that it is not systemic, that estrogen does not go all over the body. It is kind of like a moisturizer on the skin, and it's very local, and it treats that tissue. So even if women decided they don't want to do systemic estrogen, that's okay, whatever, that's your decision. But this vaginal estrogen honestly saves lives and saves marriages. And I truly believe in that, and I wish everyone had access to it because it really changes lives.
I have to say, I agree with you 100%. I am a huge fan of vaginal, because a lot of patients, like you said, they don't want to take systemic hormones, and that's fine. But vaginal estrogen really is of great benefit when it comes to vaginal health, sexual health. Agree with you 100%.
And just so viewers know what systemic hormones are, basically pills, things that are system-wide. When you use the vaginal estrogen, it's just working locally. You don't have these risks. There was a study called the WHI that said there may be an increased risk of breast cancer, heart attack, stroke with systemic hormones, but vaginal hormones work just locally. So I have to tell you, this was an amazing conversation. We want to thank you for coming on. I think that people are going to find this really illuminating. And tell people, where can they follow you? You already told us about the podcast, but plug the podcast again and tell people, where can they find you?
Oh, thank you so much. And thank you so much for having me on. I really appreciate the opportunity. You guys are amazing. So you can find me on all of the socials. So I'm on TikTok, I'm on Instagram at Dr. Sadaf OBGYN. I have a YouTube at Dr. Sadaf at FemB Health, and I also have a podcast named the Muslim Sex Podcast that people can find me. You can reach out to me. I have actually have an in-person office in New York and virtual care actually in Michigan. And but yeah, I do webinars. I did a TED Talk actually called Lessons, Sex Education for Physicians, Lessons from a Muslim Gynecologist.
Oh, wow.
And that was in Oshkosh, Wisconsin, 2023.
Wow, all
and
right.
So I'm kind of all over. But yeah, thank you so much for the opportunity.
Well, thank you for
Thanks for
joining
coming.
us. Thank you so
We'll
much.
have to do it again soon. All right, guys, this appointment's almost done. But first, our gross anatomy session for the week comes from Indonesia, where a 36-year-old man became known to the locals in his village as half man, half tree. Why? Well, because he began to grow warty lesions on his hands and his feet that looked like tree branches, so they called him half man, half tree. Local doctors were stumped. No pun.
That's your little. Okay,
No
got
pun
it.
intended, yes, pun intended. So they called in a dermatologist actually from America, Dr. Gaspari, I believe was his name, and this is what happened.
Known as half man, half tree, Dede lives at the mercy of massive branch-like structures encasing his hands and feet. When Dr. Gaspari met Dede, he took biopsy samples of his warts. Back in his lab, he made an amazing discovery. Tests revealed Dede's condition is no more than human papillomavirus or common warts. Normally, these warts would disappear eventually, but in Dede's case, they've spiraled out of control.
In an individual with a poorly functioning immune system like Dede, surgery does not eradicate the wart infection. In other words, the warts come back, and that's exactly what's going to happen with him. And that's why the surgery is not the one and only answer.
After 4 hours, all the horns have been removed from both hands and weigh a staggering 5 kilos. With the combined treatment of surgery and drugs, Dede's physical appearance is transformed. The warts have been removed from his head, body, and feet.
Ente ayah rasa kayak yang penting bisa kerja.
The remaining bones in his hands have also grown stronger.
Kebebasan itu kayak kalau di rumah kan bebas mau kemana yang bisa sama keluarga sama anak.
So after the use of medications to boost his immune system and surgery, they were able to remove the warts. And this story is kind of scary because it really highlights the fact that seemingly innocuous sexually transmitted infections under the wrong circumstances can become a life-altering ordeal. So guys, this appointment is done.
However, on your way out, be sure to stop at the front desk, talk to the receptionist, and make your appointment for the next episode of Second Opinion with the Twin Doctors. I'm Dr. I.
I'm Dr. J. See you later.